Hello and welcome to our new online series for controversies in rectal cancer. This collection of video content will allow us to explore some of those difficult decisions that our multidisciplinary team members sometimes have to make for these patients. You'll be able to watch renowned clinicians in the field give lectures on controversial topics, watch our MDT panel discuss challenging cases, and see some critical analysis and commentary. Each episode will have a common theme that runs through the broadcast. And in this episode, we'll watch Ian Daniels talk to us about frailty assessment and how this affects management and outcomes. I hope you enjoy watching.
So I've been given two questions to ask. How useful is frailty assessment in selecting treatments for rectal cancer? And how can we use the evidence from these assessments to improve outcome for patients? I'm going to take this in a number of different parts. To begin with, let's look at the epidemiology of colorectal cancer and care with age. We're all aware that colorectal cancer is very common. There are about 40,000 or more cases per year in the UK, and as with many diseases, post-operative mortality is associated with age, and it is the commonest of the GI malignancies where surgery is less performed. Rectal cancer is diagnosed at a median age of 70 in the United Kingdom at present, and the risk is highest for those around the 85 years. With an ageing population, this average age will rise. And let's remember that 50% of 70 to 84-year-olds have pre-existing cardiovascular disease, and 20% will have been treated for a previous cancer. By 2020, 60% of all malignancies are estimated to occur in those over 70 years of age. Older patients, though, are less likely to undergo surgical treatment. If we compare 68% of 64 to 70-year-olds having cancer resections, that's around 40% for those over 80. And lower rates of neoadjuvant therapy are seen in the older age group compared to young. However, as discussed last week at the European Society of Colorectal, with the results of the Stockholm 3 trial, short course radiotherapy and delay may reduce this impact. Perhaps it's better in the elderly. There is, though, increased survival in rectal cancer globally, except though in older patients. And whilst 30-day and 90-day mortality has dropped, it is less seen in elder patients, and older patients are typically excluded from clinical trials. Recent publication, which has been a collaborative effort between the European Society of Colorectal, European Society of Surgical Research, the International Society of Geriatric Oncology, and the American College of Surgeons Commission on Cancer, by Montroniak and colleagues, has demonstrated that stage for stage there is differences in treatment between those aged 70 or below or 70 and above. And taking John Carlisle's commentary on Life is a Line, Not a Dot, we know that the number of people in the UK greater than 79 will double by 2039 to about 6 million, and about 18,000 of those will get colorectal cancer. But it's not just about mortality we should be interested in. There is the considerable morbidity, there's the impact upon quality of life and level of care. What we see from these tables is that patients that come from home have increased risk of requiring support, those in supported environments requiring a need for residential or long-term care and greater dependence upon relatives. And of course we know as we get older there is a reduction in our life expectancy. So what about surgeons and patients' decision bias? Well, what does the surgeon want to know? Where were we traditionally? Traditionally, we asked risk, usually from an anaesthetist. The question to us was whether we operated or not. And that operation then principally revolved around incisions, approaches, the radicality, whether we created an anastomosis or left the patient with a stoma, and then managed them post-operatively. Alternative treatments discussed at an MDT principally involved palliative care or any oncological options available. But let's look at it from the patient perspective, or more importantly, the patient and their family. As Agatha Christie is quoted in Endless Nights, doctors can do almost anything nowadays, can't they? Unless they kill you while they're trying to cure you. Perhaps it's a question of perception from doctor and patient. And this patient perception is an interesting paper that came out last year in Diseases of Colon and Rectum by Sean Wrenn and colleagues, which looked at patient values post-surgery. What mattered to the patient? Well, third in the table was, are you going to kill me? Second in the table was, are you going to cure me? And the number one factor, am I going to get a bag, was the thing that mattered most to patients with cancer. The approach, whether it's laparoscopic, single port, TATME, robots, length of stay, incisions, etc., was right down at the bottom of the list. These were not the things that mattered to patients. So let's look at stomas and perhaps the stigmas around stomas. This is a meta-analysis from over 10 years ago now by Julie Cornish and colleagues, looking at the quality of life following an abdominoperineal excision versus an anterior resection. And when comparing the two, they identified no differences in general quality of life. The key statement here is that individualisation of care is essential, and that's now over 10 years old. Of course, when we're consenting people, it's about informing them of risk, etc. And that's brought out in the recent document by the GMC on patients and doctors making decisions together. For the patient, for the doctor, it's about the risk assessment. But not only the risk assessment, it's about the avoidance of bias in the options that we give a patient in order for them to make an informed choice. And when we look at those informed choices, we can give them data based upon populations of their risk of 30 and 90 and 1 year mortality based upon different deciles of age. But that's based upon populations. When we've got a person in front of us in the clinic, it's an individual we're dealing with. That's where the shared decision making comes. And let's not forget, surgery may cause more harm than good in some people. So how do we assess patients? Well, the global assessment is to take a history and examine people. Blood tests, scans, a discussion and an MDT, and then an outpatient clinic. But of course, there's a lot of focus these days on the process and elderly patients. 2 NC pod reports from 2010 and 2011, and a Royal College of Surgeons report looking at pre-assessment variables. When we look at the data, we can see about 1 in 6 or 13% of all preoperative assessments were scored as poor or unacceptable. That can have a major impact on outcome for that patient. When we look at assessment, we traditionally look at performance, but in reality, for the more mature patient, what we should be looking at is frailty. What is frailty? Well, this is a very good definition as a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiological function that increases an individual's vulnerability for developing increased dependence and/or death. I particularly emphasize the vulnerability for developing increased dependency. There are simple frail assessments that can be done. Simple questions, but a lot of subjectivity in them. How far can you walk? What are the factors that influence you walk? Chronic pain, etc. may be limiting. Hip, knee problems. And there are very subjective things in terms of how many illnesses do you have and what is considered an illness, etc. But increasingly there are frailty scores being used, and a number of those have been developed over time. The one that has gained a lot of traction is the Rockwood Frailty Score, as described by Kenneth Rockwood and colleagues in Canada. And this is a global clinical measure of fitness and frailty in elderly people. It is not about an age-based assessment, it's a function-based assessment. Let's look at that a bit closer. We can see there are 9 scales on here, ranging from how somebody is able to function in terms of their activities of daily living. Are they still fit and active and running marathons? Do they have dependence upon relatives, etc.? Do they have difficulties with stairs, with bathing, the normal activities of daily life, shopping and preparing meals? Or are they severely dependent and requiring considerable amounts of care before we start? We know that these are related to outcome. The probability of death within 5 years is higher if you have lower frailty scores. But also the probability of avoidance of institutionalisation, or if you are, as I identified before, already receiving some degree of supportive care, what is the likelihood you will require more care within the next 5 years? And that has its impact upon society as a whole. These scores, of course, can be used, and there are numerous different ones, but perhaps these days they should be used as part of the GP referral criteria, informing us before we see the patient of how frail that particular individual is, irrespective of age, sex, etc. And increasingly we see cognitive impairment. This is data now from 1986, but we know that the overall prevalence of cognitive impairment is about 20% and has a considerable impact on both mortality and morbidity. And cognitively impaired patients have a longer length of stay, have delayed discharge, more likely to be discharged to a nursing home, or require a higher level of home assistance. And this is not new data. This is from 1986. It was one of Kenneth Rockwood's earlier publications. Dementia, that can be added on to the clinical frailty score and corresponds very well with the degree of performance, etc. How do we assess patients physiologically? Well, we have the dedicated preoperative assessment clinics led by nurses, anaesthetists, care of the elderly. All of these involve static tests. We can develop that further into risk scores, basic physiology, and more complex physiological assessments. Static at-rest tests, these are your classic ECG, echocardiogram, lung function tests, chest x-ray, arterial blood gas, and lactate, etc. Basic physiological testing, well, most of us have got hospital corridors that are long. The 6-minute walk test corresponds very well to the VO2 max as to how far a patient can walk in 6 minutes. Walking 600 metres in 6 minutes suggests you're fit and healthy. 450 to 600, you're beginning to slow down, and there may be some restriction. Less than 450 metres, and patients are noted to have lower oxygen capacities. And that's a simple test that can be performed in most hospitals. If we go more dynamic, we're looking at cardiopulmonary exercise testing, the relationship between heart, lungs, and mitochondria. And that's quite a straightforward test to do. More than 90% of the elderly can do it. Indeed, if you cannot get on an exercise bike, a treadmill, or even use a hand crank, then your frailty and your performance is so poor. It involves increasing workload over about 10 minutes to look and see what's going on. We're assessing a number of things. We're assessing heart and lung function. We're looking for occult disease. And in the diagram you can see here, we've got two 50-year-old men who start off well on the treadmill test. The red dots suggest the lower man is demonstrating deconditioning before beginning to develop some degree of cardiopulmonary dissociation and strain, whereas the older man continues along the curve. Identifying stresses that may replicate surgery give us some indication of how we may then individualise care. And if we individualise care, that's about knowing the risks. We know that an anaerobic threshold of less than 10 mils per kilogram per minute correlates with an increased risk of complications in all types of abdominal surgery. And that can be mapped against life expectancy using the Carlisle calculator as described by John Carlisle. That's freely available on the internet. But how can we use it to plan post-operative care? Well, in the United Kingdom, one of the biggest stresses is on intensive care and high dependency beds. And this is a study from Exeter, from our unit, where we looked at patients over the age of 80 and compared them. One group were CPEX tested, one group were not CPEX tested. What you'll see is that almost half of the patients had a planned HDU, ITU stay for a median length of stay of 1 day, and a very few were readmitted to ITU. For those patients who were operated on, those that ended up in the intensive care unit immediately post-operatively stayed longer, and those that required ITU support in the post-operative phase also stayed longer. Perhaps we can use some of this data to better manage our critical care bed usage and plan for admissions rather than plan for readmissions or unplanned admissions. So, as Agatha Christie says, doctors can do almost anything nowadays, but rather than trying to kill her, can we try and cure her? Well, let's see if we can give her some degree of risk, the surgical outcome risk assessment. So a number of tools have been developed, this one from CPOD and the SOURCE database. This is the SORT process, easily available online, and you can put a number of factors in and work out. For this particular case, I've looked at somebody with an ASA 3 who's having an abdominoperineal excision, and that gives him a 3.5% 30-day mortality risk. And the emphasis here is on risk of death, not morbidity. This is more expanded, though, in the American College of Surgeons NS-QIP surgical risk calculator, which gives you more data in terms of not just mortality, but morbidity as well, and shows where risks are higher or lower than average. Again, perhaps this is a way to use and focus care more effectively. These are now app-based. I show you the one used in incisional hernia. The CDAR score can be used in the outpatient clinic to demonstrate to the patient what changes can be made by them making changes in their lifestyle. Indeed, the sort is now also available on an app. But what we really want to be able to do is demonstrate to the patient what changes may need to be made in order to plan for their more successful surgery. Let's look at patient optimization prior to surgery. Well, mitigating factors such as anemia. We've long known that the more anemic you are, the more the impact it has on your anaerobic threshold, and therefore the focus on preoperative normalization of your blood is well recognised. And indeed, these days, we should rarely be operating on people for elective surgery who are anemic. There is also the wider assessment of called the 3 pillars of managing blood, about optimizing hemopoiesis, minimizing blood loss during surgery, and then increasing and harnessing and optimizing tolerance to anemia, whether that be preoperative iron infusions, etc., as part of trials, but also better attention to surgical techniques and recovery. Smoking cessation. This is a difficult one when we balance it in terms of surgery. We know that 16% of adults in the United Kingdom still smoke. We know that smoking is associated with poor healing. But in terms of smokers and the generation that we're talking about, perhaps what we're seeing the smoking generation, many of whom smoking was seen as healthy through the 1950s, 60s and 70s. And with public campaigns now, perhaps we will see less and less impact of smoking in future generations of the older. Then we've got optimising their medical care, optimising their diabetes, getting their HbA1c as low as possible, blood pressure, cardiopulmonary obstructive disease, managing the antiplatelet agents such as aspirin, clopidogrel, the role of lipid-lowering agents and beta blockers. And there are now guidelines for so many things, including diabetes and blood pressure, etc., preoperatively, for which we should be following. This perhaps is the role of the perioperative physician, dare I say the perioperative geriatrician, for the group of patients that we're looking at. Body mass index is less of a problem in the elderly, but of course across the United Kingdom it is becoming an increasing problem, as in many other parts of the world. So perhaps in the future we'll be dealing with the impact of obesity in the older generation, whereas in the past we dealt with the smoking impact. That's something to look to in the future. Prehabilitation, getting you fit for surgery. That's now reached the realms of the newspapers, etc., and we know that prehabilitation can maintain muscle mass, reduce the impact of sarcopenia, get away from that bed rest, and improvement in cardiovascular fitness. For all those that cycle and do other sports out there, it's all about improving robustness and getting people fitter. We know that works. We know that improvements in the 6-minute walk test can be used to look at with a prehabilitation in the paper from Gillis et al. That showed that the impact of a prehabilitation program was maintained before surgery, after surgery in the long term. And in the area of neoadjuvant chemoradiotherapy, continuing somebody's prehabilitation and getting them fit between the treatments improved the outcomes following surgery. Patients got over their treatment, and in the 14 weeks between were enrolled into a prehabilitation program that improved their fitness. We'll see perhaps more of this through the Prepare ABC trial, which is currently ongoing. So, when we're improving outcome, can we do shared decision making? It's about the relationship between the surgeon, the team, and the patient and their family. We know that there are more 80 and 90-year-olds. What we're not seeing is more people into 100 plus. We're not suddenly increased life expectancy to 110, 120. What we've seen is a shift in the curve that people remain in their later years. But still, whilst there's a small rise in the number of people in their 90s, there's a smaller rise in the number of people over 100. So it's about those last 20, 30 years of life and how we maintain and how we manage them. We know that as we get older, obviously there is an increased risk of dying. So 5 and 10-year survival data is irrelevant for people in their 80s and 90s. Perhaps we should be looking at different outcome measures. And then, of course, we should also be looking at the populations. It's easy, and I've chosen this paper as an example, to look at how we might optimise the management of rectal cancer in older patients. But we're optimising treatment here. We're not necessarily optimising outcome. We're not looking at the different roles of different treatments, and we're not looking at the impacts, such as the low anterior resection syndrome and function, and the impact upon stoma rate. The risk, though, of a stoma is not small. This is data from the French data set for people who've had a low or ultra-low anterior resection, and have still got a stoma 10 years down the line, about 20%. Each of that contributed mainly by anastomotic morbidity, incontinence, local recurrence, or their stomas never being closed. Where does that give us in the United Kingdom? Well, this is NBOCAP data from 2016, looking at the period 2011 to 2014. A third of rectal cancers have permanent end colostomies, and a quarter of loop ileostomies had not been closed, with half of the patients who've got stomas still maintaining them at 18 months post-operatively. Of course, there is wide variability between regions and hospitals. But the converse is about joining people back together. And this meta-analysis by McDermott and colleagues demonstrated that age alone is not a clear-cut risk factor. But of course, many of the non-adjustable risk factors are associated with increasing age. Therefore, perhaps we get as very simple, and we suggest that end colostomies for all. But of course, that's a very simplistic approach, and again, that's not based upon the patient that we have in front of us. There are some now beginning stratification ways to try and look and see what is the best outcome. The International Society of Geriatric Oncologists beginning to look down at different pathways of care for different people based upon their frailty and their fitness. And in the paper by the group, then there are different routes down that based upon standard care. It mustn't be seen that standard care is perfect care, as in the very fit individual, but we ought to be able to standardise our care for different people at different levels of frailty and fitness. Indeed, it's important to consider the predictive factors for poor function if a loop ileostomy never gets closed. Of course, if we don't close an ileostomy, well, we know that the older you are, the less likely it is to get closed. We also know there's not an inconsiderable morbidity associated with ileostomy reversal. And of course, there are reasons to be readmitted, predominantly acute kidney injury and dehydration in these patients, which can have a considerable impact upon function. The factors that affect the timing and closure and non-reversal, well, in this large Dutch series, the older you were, the longer you waited. So it becomes nuanced decision-making. The main message should not be to increase the number of non-restorative procedures, but instead to reach a better understanding of which patients will be able to complete their surgical journey. And I'll leave you with the identify which patients will complete their surgical journey successfully, individual decision-making. What about the extremes of age? Well, in those over 90, there's a return to independent living and awareness of likely outcomes can be used to help decision-making in the extremes of age. Let's not forget that for many patients over the age of 90, they've probably got children in their 60s or 70s. Indeed, some of their children may have predeceased the 90-year-olds. And many of these people may have discussed end-of-life scenarios. Perhaps that's a discussion that should be had with all ages as to how a patient wishes to see out their days. The MDT, having a holistic outcome discussions, can be quite challenging without the patient, family and people that have met them. So perhaps there's a greater role for the geriatrician. Indeed, perhaps the geriatrician should be the primary carer, because what we're focusing on here is the quality of remaining life as opposed to the quantity of remaining life. Our data of over 90s from the southwest of England treated in a district general hospital, about a third underwent elective surgery. The very few emergency operations, many managed conservatively and a few palliatively. And so let's look at the outcomes from some of those. Well, the principal outcome was where you came from. If you came from a nursing home or community hospital or residential home, you were unlikely to get elective surgery. Those that were already pre-able and maintaining a home environment, more so. But were there differences between the types of surgery that went on? So what we can see that as we move from right-sided to left-sided to rectal tumours, indeed, elective right hemicolectomy or right colon cancer surgery led to good results in this small group of patients. Almost 90% returned home, 30-day and 90-day mortality was acceptable. But as we move towards the left side of the colon and the rectum, we can see more increased use of palliative means or defunctioning stomas and less complete resections, etc. And so it becomes a stage not just on the tumour, but on the patients as well. Good outcomes can be achieved in some ages, provided we choose the right patient and the right outcome. What about future trials? Well, in this year alone, we've seen a considerable number of trials. The ELF, the Emergency Laparotomy and Frailty Project, has been published recently in Annals of Surgery and is available online. And the Neoadjuvant Chemoradiotherapy and Prehabilitation REX trial has also recently been published in Colorectal Disease online. Big data allows us to question some big decisions. This is data from France, looking at rectal cancer over 1 year in just over 45,000 patients and their outcome. And we can clearly see that based upon the number of cases done by an individual centre, there's a difference in 90-day mortality, to lead in France to the conclusion that the predictive operative mortality after proctectomy for rectal cancer is strongly associated with hospital volume, independent of patients' comorbidities. To improve post-operative outcomes, rectal cancer should be centralised. These are challenging times ahead for our political masters and colleagues. In terms of clinical trials, well, in many ways that's being led both by surgeons and geriatricians. This is the Go Safe study, or the Geriatric Oncological Survival Assessment and Functional Recovery Following Surgery. It's evaluating patients' life perception by comparing their pre- and post-operative. It's multi-centre, it's prospective. And principally, it's being involved a geriatrician and being led by geriatricians, and is looking at a whole host of different outcome measures and methods to measure to see what impact each of those has to allow us to make better decision making. There, of course, is the comprehensive geriatric assessment. What we're aspiring to is improving care for older people in hospital, both as they come in and as they go home. A comprehensive geriatric assessment is an interdisciplinary diagnostic process to determine the medical, psychological and functional capability of someone who is frail and old. The aim is to develop a coordinated, integrated plan for treatment and long-term support. So what conclusions can I draw? Well, the recognition of the changing demographics of patients with colorectal cancer. Essentially, we have to plan for what is coming over the next 10-20 years. There is the comorbidity and functional element to this, the quality of life, the impact on activities of daily living are of increasing importance. The PROMs, the patient-related outcome measures, will come to the fore. No longer are length of stay, time of operation, etc. important. Decision-making aids. Now we're beginning to see in outpatient clinics that we can accurately work out for individuals in front of them what their risks are to allow decision-making. But that shouldn't decision be made at that point. Patients and their families should go away to digest the information, to come back and discuss further. The shared decision-making, though, has to be recorded. It's important for continuity of care, consistency of care, that we're recording those decisions. New methodologies and clinical trials are coming to the fore. No longer is it a randomised or a cohort study. There are some new methodologies to look at individual populations and individual interventions. But most of all, it's a recognition of the risk to the individual as well as the risk from the surgery. So, in conclusion, I'd like to thank you for inviting me to speak today. Thank you.
What a fantastic lecture that was. And we'll be discussing that in more detail later on in the programme. But for now, let's look at one of our complex MDT cases that was discussed earlier in the day. Hello and welcome to the Iceni Centre's Rectal Cancer Multidisciplinary Team meeting. My name is Greg Wynn. I'm one of the consultant colorectal surgeons here in Colchester in the UK, and I'm delighted to be able to invite here today an expert panel from around the country to discuss these difficult cases. Before we start, I'd like to get them to introduce themselves to you.
My name is Tan ARULAMPALAM. I'm a colorectal surgeon at Colchester Hospital.
Hello, I'm Ian Daniels. I'm a consultant colorectal surgeon at the Royal Devon and Exeter Hospital.
Jim Khan, consultant colorectal surgeon, Queen Alexandra Hospital, Portsmouth.
James Kinross, consultant colorectal surgeon and senior lecturer at Imperial College in London.
Anna Wordley, clinical nurse specialist in colorectal care at Colchester.
Alex Stewart, clinical oncologist in Guildford with a particular interest in brachytherapy.
My name is HUGO Ford. I'm a medical oncologist from Addenbrookes Hospital in Cambridge. My name is NAJIB HABOUBI. I'm Professor of GI Pathology in Manchester, UK.
This is an 84-year-old lady with a BMI of 25. She's got a performance status of 1. She's got an old hip fracture which really severely limits her mobility. In fact, anything over 20 yards and she has to use a wheelchair. She's presented with a change in bowel habit and rectal bleeding. Her past medical history is she's on 3 medications for hypertension, and she's had a midline laparoscopy for a hysterectomy many years ago. Examination reveals a palpable low anterior tumour at 4 centimetres from the verge, about 40 millimetres in diameter, and colonoscopy has failed in the sigmoid colon due to diverticulosis. The rectal biopsies confirm adenocarcinoma. I don't think we've got endoscopic pictures for this lady. So Darren, can we have some staging for this lady, please?
Of course. So she has a low to mid rectal tumour. It's quite long, around 5 or 6 centimetres in length, and it's near circumferential, and you can see that the rolled edges are at around 7 and 8 o'clock. Tumour leading edge at around 2 o'clock here. At its lowest extent, its distal edge is around 5 centimetres from the anal verge. Now it's encroaches a little into the mesorectal fascia, there's at least 4 or 5 millimetres of invasion into the mesorectum, with some desmoplastic reaction adjacent to this, and also there is some fairly convincing small vessel non-atomic vein extramural venous invasion. A few tiny nodes, none of which reach size significance, but have some mixed signal intensity, which makes them slightly suspicious for involvement. So overall, I'd say this is a mid to low near circumferential T3B N1 tumour with small vessel EMVI, but the circumferential resection margin is very well clear of the tumour. Incidentally, there's a slightly unusual adnexal cyst with some complex elements which will certainly need further investigation in a lady of this age, presumed postmenopausal. The CT is reassuring, with no evidence of distal disease.
Good, okay, so her CA125 was normal and previous scans had shown that that cyst hadn't changed, so was ignored. So, Ian, you're about to see this patient in clinic. She's 84, limited mobility, frail. What's going through your mind before you sit down with this patient?
So, ideally I'd like to see the patient with her family. I'd like to see who she gets her support from, etc. What level of care she's receiving. This is not somebody that I want to be seeing cold on my own. I'd like to see her with her supporters, and also we'd always see these patients with specialist nurses, etc. Often who've met them before at the time that they've come for investigation, or at the time that they've been diagnosed in endoscopy. So, for both the patient and I, then all being well, that groundwork has already been done, and then what we're beginning to do is discuss what the different treatment options are for her, and what her expectations are, and what her family's expectations are.
Jim, has it got any sort of role for local excision in this case at all?
I'm afraid not at the moment, as the way things are, because it's a circumferential tumour. It's about 5 to 6 centimetre long. That just about puts it to the limits of where you can push it in terms of local excision. And we also seen some nodal enlargement, which obviously local excision will not treat or address that issue. She may be at risk of obstruction, and that needs to be assessed as to how much circumferential luminal narrowing she had. I understood that colonoscopy was impossible, but because of diverticular disease, not because of the tumour causing obstruction. So as such, at presentation now, I'm afraid local excision will not be an option, but whether we consider her as a high risk for surgery and consider organ preservation and downstage this and then reassess that.
Okay, she says, I'm too old for a big operation. I just want to keep my symptoms under control and have a few more years of good quality life. So we're going to need help from our oncology friends. Comments?
Well, from the chemotherapy point of view, I'd be quite reluctant to offer this lady chemotherapy as a single modality. I think, particularly if she's angling towards quality of life, she's fairly elderly, she's got significant comorbidity. So I think the question for me would be whether, you know, whether she's well enough for chemoradiation. And over to Alex.
Yeah, so surgery would be ideal for her, I think. But if she did get calculated with a morbidity risk that was too high for her to be acceptable, or if she didn't want it, then I would offer radiotherapy alone. I probably wouldn't offer her chemotherapy with the radiotherapy at 84. The HABOUBI study, which was a Dutch study, used external beam radiotherapy for 13 fractions, so 39 gray and 13 fractions, and then gave 3 fractions of HDR brachytherapy, which is a kind of brachytherapy that's able to give a circumferential dose. And so that is what I use in patients that are refusing to have surgery at all. So it allows us to give a much higher dose with a larger boost dose, but it's different from the contact brachytherapy in that it will go deeper in and it will potentially cause more scarring. So I need to know that the patient will not be having surgery, because it could potentially make surgery much more complicated in the future. So if she did have a recurrence, she may have a defunctioning stoma or such like, but wouldn't be planning for any pelvic surgery.
Is this a palliative treatment or
It's basically a high-dose palliative, but it is potentially curative. So some patients will be cured, possibly due to their other morbidities becoming prevalent before that. But it is a very high dose. I can also use that kind of treatment for very localized palliation and just give them a single treatment or such like, or just 5 fractions of external beam radiotherapy as well, if I'm looking for a much more hands-off approach.
Okay. All right, let's see what happened. So she's too old for a big operation. She was referred for palliative, in inverted commas, short course external beam radiotherapy. What sort of dose would a typical palliative?
That would usually be 25 gray and 5 fractions.
25 and 5.
Can I just ask, would you be concerned, given that she had a previous hysterectomy in the site of that tumour, in terms of the relationship to her small bowel, to give her radiotherapy? That would be covered?
Absolutely fine.
Okay.
Yeah, it's a very tolerable dose.
Bone, because she had bone fractures in the past. Is that okay, safe?
Yeah, so her mobility is so poor that probably any effect on the bone is not actually going to be noticed anyway. But the risk of microfractures is of an exacerbation of osteoporosis. So if she had osteoporosis under control, then there shouldn't be a significant risk of extra microfractures.
Okay, I'm just going to throw this open to the whole panel. What's the next step for this lady? If she has radiotherapy and we're assuming that it's just to control her symptoms, are we going to follow her up? We're going to restage the patient? Or are we going to see her just as and when she develops new symptoms?
I would discharge her back to the care of the GP, and I would liaise with my specialist nurse colleagues, so to make sure that a patient has the specialist nurse's details and that they can call straight into the specialist nurses if they have any symptoms, and that we'll see them that week if they have problems, but we won't be bringing them up and back to the hospital.
I would agree with that. I think it's always helpful to divide and decide upfront which paradigm they're going into. Is it a curative or a palliative? And I fully agree that there are some patients who will be borderline and it will evolve as things go. But if we are very clear that she's elderly, frail, does not want major surgery, and intensive follow-up will not be of any significant use, we probably will be looking for or trying to foresee any complications that might be coming our way, maybe with fibrosis or stricturing or risk of obstruction, and we will try to have that follow-up between the nurse specialist and the GP.
So I might go as far as to suggest that from a surgical perspective, then there is no value in me following up and her coming to my clinic. I'm going to offer her very little. Given the presentation and all the rest of it, I may well have engaged the geriatricians in her care in terms of managing her symptom control, and indeed the community palliative care team, with the emphasis that palliative care is about symptom control, not about end-of-life care at this point. Because you know, the service is under enormous pressure, both in general practice and acute care. Actually, it's giving this person a lifeline and somebody to get hold of and a team that's managing. So I think we can gain an awful lot from referral to palliative care early, if only to keep on top of symptoms and advise in the community and keep somebody in their own home. Because I'd fear for this lady being readmitted to hospital later on that she may never get home.
Is that a significant workload, Anna?
It can be, yes, because those patients who have their symptoms made significantly better by this kind of treatment, the community palliative care teams are not able to take referrals for them. And we do find that these patients often fall between a bit of a rock and a hard place, that the GP practice and services aren't set up to manage these patients. You know, the matron often isn't interested either. So it does sometimes fall to the CNS to be trying to do some sort of follow-up, you know, telephone follow-up. What we've found more recently is that, you know, ringing these patients every 6 weeks, couple of months, you know, you often have the response, well, you know, I'm out shopping at the moment. So we have had to sort of review that because it is a large amount of work. But there are, I think, certainly within this area going to be some changes to put in some Band 4, Band 5 support out in the community to sort of liaise more completely between, you know, the hospital services and the GP practice services for those patients who aren't ready to go on to specialist palliative care.
I think we underplay the value in continued care by the same individual. Because one of the difficulties is that if you're seeing a different healthcare professional at different times, they don't have a baseline on which to work from. So, you know, you making a phone call, somebody making a phone call that has met that patient will have a relationship with that patient.
Absolutely, yeah. Yeah, no, I agree. But, you know, I think with the holistic needs assessments that we do at key points in the patient's pathway, you know, there's no reason why that can't be handed over to the community team for them to sort of, you know, take that baton, really.
Okay. We did restage the tumour 10 weeks after short course radiotherapy. Darren, can you just let us know what you've discovered?
Okay, there's been a very striking reduction in the tumour volume. Unfortunately, the artefact from her metallic hip prosthesis runs straight across the tumour, but even still, it's very difficult to see in the sagittal plane. Magnifying tangential to that, you can see there's a dense fibrous scar running around the site of the previously quite bulky tumour epicentre, and a tiny focus of mucinous change. The EMVI is resolved, the nodes are no longer of mixed signal intensity, so a very good response. There is still some intermediate signal intensity within this, so this is not a complete response, and one could argue that despite quite a marked decrease in the tumour volume, tumour signal still predominates over fibrosis. So you'd call this a TRG 3 or 4 by MRI criteria, but certainly a very good response. CRM remains clear and no new worrying features, and the CT was also still clear.
Okay, so a reasonably good response. That's now what it looks like. What do you think of that, Tam? Is that of any value to us at all, or?
Well, in terms of follow-up, having a look is useful, but as Ian has alluded, we're sort of, you've got to decide which way you're going and give the appropriate support. So we've given some palliative treatment, and now we're following up, and one has to ask what the purpose of that is. In terms of this image, it's useful. It shows us that the mucosa's regressed and is healing. Sign of a complete response is the nice pale mucosal appearance with some telangiectasia. It's very difficult to judge what this actually is. We know that biopsies have got a very poor positive predictive value, 11% or so, based on Fraser Smith's work. So having a biopsy here is not going to help, because if it's negative, it doesn't mean too much. So with this information, you can tell the patient, well, you've had a good response. The question is, what do you do now?
Yeah, I think you can reassure the patient that their cancer has not progressed. Yeah, and this lady has, is continuing out there in the community. So we've got that to say you've had a response. It also gives you that, I guess, that option that any further symptoms she may has are not necessarily due to the cancer, but could be due to the treatment. Yeah. And so it's about symptom management. But given our initial presentation of the patient, etc., then are we going to take that further other than to wait longer?
I mean, we could ask Alex whether there's any role for contact, but I guess...
So if you saw that, actually, yes, you could give some contact brachytherapy to that site, but I wouldn't have predicted that I would have been able to give contact brachytherapy, and the current NICE guidance that has come out would say no, but for the fact that if it's downstage now to a T2N0, then that would bring it back within the guidance. But I would worry about deeper invasion. But again, going back to that initial point, I would have said this is palliative. That's all we're planning towards. That's what we're working towards.
So it's very interesting, the work that Gina's done on converting EMVI positive to negative. So Darren, I missed that part of your report. She started off EMVI positive, non-anatomical tumour islands. Has that improved? That situation improved?
The EMVI is completely resolved now. So no evidence of discontinuous tumour deposits, although there weren't previously, but certainly the venous changes have resolved.
Okay, someone's done another MRI 6 months later. Perhaps because the patient has asked, is this going to go away? So let's have a look at the scans.
And indeed it has, in as much as it's a complete radiological response. Tiny little focus of mucinous change at the epicentre, a dense fibrotic scar, no evidence of lymphadenopathy, no EMVI, no convincing evidence of residual intermediate signal tissue. So we would call this TRG2, but a complete radiological response.
So I suppose we better put the camera in again and have a look and see what it looks like. Now it looks like this. So 10.
So that's as I described, for a complete response. Nice blanched mucosa with some telangiectasia. And I guess you can, once again, reassure the patient that this is not progressed. In fact, it's resolved further. The problem now is, having talked about palliation in the community and follow-up, we're now perhaps in the obligatory situation of having to continue to follow her up at the age of 84, I think it was. And I think that's a very difficult situation, because whoever you are, whenever you have a follow-up test for cancer, it causes a huge amount of anxiety in the individual, in the family. She's wheelchair bound, she has to get in for these tests. So one would say that it would be ideal to sit down and decide how we're going to manage this lady in the months ahead, because it may be, as Anna said, that we now simply wait till she becomes symptomatic.
That leads to the question, though, that to begin with, we didn't feel that she was suitable for aggressive operative management in one way or another, and we've given her a treatment. She's 6 months older. Her frailty was already marked in terms of her performance, etc. She may well be maintaining a degree of independence, but anything further that we may consider is going to lower that. It's going to make her more dependent. So at 6 months, down the line, and at 84 years old, we're not looking at 5-year survival rates here. We're looking at symptom control. Why not discharge her back to the community?
So I would agree with you, and I think this goes back to the point James was making, that if you are not a specialist centre and you may be doing this on an ad hoc basis, which many MDTs are doing, you can't get any proper data, because this lady's biology is presumably pretty good. So she's self-selected by chance. We didn't predict this.
So there is an international watch and wait database that's run from Amsterdam. So for patients that achieved a complete response like this, they can be entered into the international watch and wait database. And as time goes on, that should tell us more information about perhaps which patients this has happened to. And that's as opposed to the Guildford database, which we run for patients who we're planning to achieve organ preservation. The international watch and wait database is for those that in general have achieved organ preservation due to the external beam radiotherapy that they've had and initially were planning for a surgical approach.
But I might just challenge you on that, in that there's an inherent bias here that this lady was highly unlikely ever to achieve organ preservation because of the risks associated with major surgery.
Yeah.
So we're implying inherent biases at a number of steps in the process here. What we've effectively done is we've individualised her care, whether we've done it in the planned way, but she self-selected herself out by the interventions that we've done so far. And she has, to date, had a good outcome.
Yeah, so there's the database will tell us those outcomes, but as you say, it only tells us the outcomes of those that achieved a response, whereas the database that we have will tell us those that achieve the response and those that don't achieve the response. So that should, we've got two balancing databases there, but there is a database to put her into to
How often do you get this regression with short course? Because we were actually the first people, I think, when we divided into long course and short course, we find that we advertised that actually you can get a resolution or regression in short course, and we were crucified at the time.
Probably be looking, if you look at patients that have short course and then a delay to surgery, probably looking about 15 to 20% pathologic complete response.
Yeah.
But we have,
And so if you're looking at the ones that then maybe probably 50% of them recur, so you're looking at about a 10% chance that she would achieve and maintain a complete response from this approach.
so we've published on radical surgery in the over-80 group, and the 90-day mortality may be significantly higher, reaching perhaps between 15 and 20%. It sort of does sort of fall off a cliff very quickly. So we're here talking about 6 months, 9 months, and whether we've done the right thing. If we've did surgery, you may have a 1 in 5 chance of not surviving 3 months, and I think that context is very important.
Yes, Fraser Smith did some work with HABOUBI's group to show that for patients over 80, some decision modelling shows that a watch and wait approach has a 10% survival advantage, which is probably taking away that perioperative mortality. So it's certainly, again, as a planned approach.
And I think this goes back to James's point about thinking in reverse. Some people may say, well, actually, if those are the odds, I have some other priorities in my life, not just your oncological R1 rate.
But we can work out what her risk of dying is given her age and comorbidities, irrespective of the cancer. And whatever treatment we give her has to be balanced against what her life expectancy would be with her fitness and frailty at the point of time. So, I would suggest that partly by default, but this lady's had a very good response, in the first 6 months.
Can I just say, from a patient point of view, I think if we had treated her and then just discharged her out of our follow-up, I completely take your point that coming back for follow-up tests can cause some kind of, some form of anxiety, and we know that it does. But this lady would have been living thinking that she still had disease, and that may well have impacted very much on her quality of life. And actually having these fairly easy to do tests for her have given her, a better a better picture, really.
So I think you've hit the nail on the head. This lady really does want to know whether she's still got cancer or not. It's really the not knowing that's causing her more anxiety than any further tests. She's only 6 months down the line, so we pursue a diagnostic pathway. So Darren, this is now 9 months post-treatment.
Unfortunately, what we can see now is that at the site of the previous dense scar, she's developed a small, it's a sub-centimetre nodule of intermediate T2 signal intensity. In this plane, which is essentially the axial plane, she still has her normal preserved muscularis propria signal intensity, so you'd call this a T1, but certainly very close to the muscularis propria, and in fact, going through 90 degrees in the coronal plane, you could probably just about see there's a little loss of T2 signal intensity just there. So it's either an SM3 type lesion or an early T2, but convincing evidence of local recurrence at the scar site, scar fragmentation. The mesorectum continues to appear absolutely clear, particularly at the site of possible breach, and there's no lymphadenopathy.
Okay, so further endoscopy was performed. So I'm coming back to you, Tan, again, because you're the endoscopist following this patient up. So what do you think of that?
So she's got a regrowth, definite change from the previous findings. I still stand by not doing a biopsy. And I think this has to be taken in the context of what we've seen on the MRI as a regrowth, and we have to make a decision as to how to manage this based on her symptoms.
Okay. You know what's coming, Jim, don't you?
Yes, exactly. So this lady now knows that she had a good response and is coming back. I suspect she might not be very symptomatic with all this. This is a radiological pickup and then an endoscopic pickup now. And maybe a good one in a sense that you do have a couple of options to think about. And we probably will be back to the kind of drawing board to sort of sit with the family and with her and discuss and say, well, look, do we go for a local excision in this setting, a TEMS excision of the scar, or do I pick the phone up and ring Alex for help with some brachytherapy? Or shall we wait till she gets more symptomatic and follow her up later? So the three options will be on the table. I think for me it will be assessing her operative risk again. Is she a candidate? Can she withstand an hour anesthetic procedure with TEMS and the possible risks which will come with post-radiotherapy TEMS excision of this? This is a low tumor, so I suspect it will be extraperitoneal rectum, which will be fairly safe to do. It's localized to one quadrant, which looks to me within the realms of TEMS excision. We are not seeing any nodal enlargement in the mesorectum. We're not seeing any EMVI on the MRI, so that still qualifies her for a TEMS excision. But if she, on the other hand, has deteriorated in her health, has got significant cardiorespiratory comorbidities, then perhaps brachytherapy would be another option to explore.
Can I just ask Alex and you, Jim, my experience of these patients doing local excision when they've had chemoradiotherapy, they develop a new set of symptoms, that the leakage is quite debilitating. So the question is, if you could give contact and you elected to do so, do they get similar sort of leakage?
As far as we know, they don't tend to complain of leakage, though we are setting up a large PROM study to tell us that more sensitively. Bleeding, possibly, though she's only had 25 gram 5 fractions. We tend to offer 3 or 4 fractions. For this one who'd had a complete response with a regrowth, we'll probably offer 4 fractions of Papillon treatment to her. And they tend to have a good symptomatic result. And what we then suggest, because we're offering that, and I think in exactly as you say, the patient likes to know, especially with the Papillon, which is a more invasive procedure, that they've gone through it for a reason. So we do suggest an MRI and sigmoidoscopy, one single one afterwards, to see what result we got, and then to stop imaging. But I would personally prefer to do the contact brachytherapy at this stage, rather than waiting for it to grow bigger and get symptoms, because then I think you're dealing with something quite big, potentially quite radio-resistant. Mucinous tumours are more radio-resistant, so it is going to be a little bit difficult, but I think for palliation you'd probably get a better effect with contact brachytherapy than local excision at her age with her comorbidity.
Would the location of tumour concern you, Alex, in terms of being anterior or posterior with the vaginal contact?
So for a lady who had hips like hers and the poor mobility, she would be lying with her legs in lithotomy for the treatment. It can be a little bit difficult to get to an anteriorly based tumour, but we're working in an operating theatre. We can move the bed around, so usually we're able to get adequate views. If patient's able to, then we put them in knee chest when they've got anterior position.
So what I meant with that was the risk of fistulation, with rectovaginal fistulation with high dose radiation.
So there's only 2 fistulae described in Professor Sun-Mint's series of 1,000 patients, one of whom had had significant surgery previously for a polyp, which had just been repeatedly removed, and then the polyp had cancer. But both cases were anterior. But with these doses, with this short course radiotherapy and full fractions of brachytherapy and no previous surgery, it should be a minimum risk.
So the patient is only on treatment for hypertension and her mobility is limited by an old hip fracture. So she's not terribly comorbid. Her hopes have been raised by the fact that the cancer may have gone away completely, and now she's being told she's got a small regrowth. She wants to know whether she's curable now and what's her best chance of cure. She wants all the options. What do we think her best option of cure is?
Surgery. I mean, if she can have a proper resection, that's going to be her best chance.
If there's cancer, get it out.
Accept it now.
The only way that you'll be able to tell her that is if you can tell her what the actual biology is, and that means looking at it with a microscope.
Okay, she's had an uncomplicated TEMS.
Yeah, and the pathology was an R0, T2, and there is only one lymph node which was involved in the specimen incorporated, and that was negative. And there was no another disadvantages or poor prognostic features in the biopsy. I mean, the histology says it is multi-differentiated. I actually usually ignore the differentiation after radiotherapy. It doesn't mean anything. So I think it has no value. Anyway, but it is actually, it's one of those good tumors.
Okay. So she's gone on to have further surveillance in your clinic, Anna.
She has. I saw her 2 weeks ago.
She is recently been seen 3 years down the line, and she is disease-free and with a reasonably good quality of life.
She has a very good quality of life, yeah. She's very happy with everything. Still very good support from her family who have supported her through it all.
Good. Okay, so
you cured her hypertension too.
Sorry.
She was hypertensive, you said.
She was.
And now she's okay.
She's still on her medication. Okay, so the key learning points from this case are to discuss alternative strategies for those unwilling or unfit for radical surgery. It's often unclear whether someone is palliative or curative at the outset of treatment, and that can change from one to the other, of course. So we're back here in the Iceni Centre to discuss things in more detail, and with me I've got my colleague Professor Tan ARULAMPALAM. Welcome, Tan.
Hi, Greg.
I think Ian's lecture was absolutely fantastic, wasn't it? And the thing that I got from that was that our population in people over 70 in the 80s and 90s is going to grow significantly over the next 20 or 30 years. And really, as colorectal surgeons, we have to be ready and waiting for this onslaught of older patients. And I think we need better strategies and pathways to deal with these patients. No longer are we going to be looking at radical surgery or palliation, but we need to find different ways of treating these patients so that we can get them through their cancer journey, hopefully with cure, but otherwise with good quality of life. And our MDT case showed that in some detail as well, with an elderly patient who did find short course radiotherapy and then a wait and then maybe a local excision was perfect for her in her circumstances. What do you think were the key parts of that lecture that shone out for you?
Well, isn't it interesting how much things are going to change over the next 5-10 years? In fact, the change has already happened. When I started as a consultant 15-16 years ago, the average age of my colorectal patients was about 74, 75, and now they're approaching late 70s and early 80s. And you know the paper that we have published from Colchester has shown that in those patients over the age of 80 who have radical surgery with curative intent, we have a mortality at 90 days, not the 30 days, of approaching 15-16%, and the literature shows that there's a spread between 15 and 20%. So if I said to you as an 80-year-old, 85-year-old, listen, there's a 1 in 5 chance that you may not be alive in 3 months' time, having undergone this massive surgery, you may think very differently. I mean, I don't know what your views to that on that data are, because that's what Ian was referring to.
I think there's a lot of work to be done in getting proper assessment of this patient population in our clinics around the country into better shape. I'm not sure we're doing that as well as we could be in terms of trying to quantify the risks for each different treatment possibility for the patient in front of you, to give them a really proper individualised and tailored care.
So that point's very important. It's the individualised care, and it really starts off in primary care. So when these patients are seen by their GP, some sort of assessment has to be made. So Rockwood is a great, the Rockwood Frailty Index is a great score. It's very simple. And if you have that information on the referral letter, and the GP is able to manage expectations, then you can actually start thinking about it in the clinic. I think frailty assessment is so important because on the flip side, of course, 80% of patients do survive, and I think it's important to think about that 80% as well. So we know that in the world literature, about 60 to 70% of those patients have some sort of reduction in their frailty. So if you're familiar with the Rockwood scale as you are, you can get knocked down 2 levels. So put that to the patient, and when you're doing, as you mentioned, the individualised care, they may say, well, actually, my function is going to go down that much. I'm going to be in a wheelchair for a while, and some of them will recover. But I think what's really striking is 10% of those patients won't get back to their own accommodation. And then family or loved ones who come into the clinic will start to think, wow, this is my grandmother, grandfather. Everything changes.
Do you think we're doing as much as we can be in terms of prehabilitation? We're very much looking at sort of getting patients rushed through to their target date for the first treatment. In fact, when in this group of patients, they need a lot more time, I think, don't they? And there's an opportunity there for us to get them fitter for whatever treatment they're about to have.
Absolutely, no doubt. Optimisation before surgery for this group of patients, in fact all our bowel cancer patients, but in this group in particular, because they're so vulnerable to the changes in physiology that you and I impart on them. So, simple things: smoking cessation, alcohol. But the really important things that that we should focus on are nutrition, making sure their hemoglobin is checked, and we give iron infusions if necessary, and some sort of mobility and exercise program. And these are simple things. If you look at the CT scans of these patients that are coming to surgery, they have significant sarcopenia, psoas sarcopenia, which can, we do pre-op CTs to look at to stage these patients, and if you look at the psoas muscle, you can see the reduction, and that's a measure of their frailty and their nutritional status. So I think it is important to work on those aspects, and I think it empowers the patient. So this isn't about you and me getting an R0 resection and reduced recurrence rates. This is absolutely patient at the centre and saying, what can I do for you? You're not an Olympic athlete. What can I do to make your journey the best it possibly can be?
Great. And this is only going to be an increasing problem for all of us, so we need to think very carefully about our strategies for this.
I absolutely. This is, I hope that this online series will stimulate the viewers to go back to their MDTs, to go back to colleagues and say, listen, shall we actually think about frailty? Shall we actually talk about it and perhaps have a change in their practice because of what Ian said, and the demonstration in the MDT that actually there's radical surgery, there's palliative surgery, or palliation, which is the patients may not particularly want. There's this grey area in between, and I think that's the space to be explored. There's a lot we can do.
And just finally, I just want to talk about Papillon technique, which may be applicable in this age group. Very positive results coming out of trials and our experience here in the UK, but there aren't enough of them in the country, and patients have to travel vast distances to go, which really isn't very good for this sort of patient population. I think we need more machines, don't we?
Absolutely. It is a great technique. I think the patients have to be told about and counselled about the technique. But if they get over that hurdle, it's a great treatment modality. But if you're then telling them you've got to get in the car and travel 4 hours, 5 hours to have the treatment, it just becomes a bit more difficult. So I 100% agree. And I think our oncological colleagues need to also be the catalyst for these change, because somebody's got to do the business case, that horrible word. And you've got to persuade the powers that be in your trust or cancer group that actually this is an option. And for me, it's a no-brainer that, by 2025, our population over the age of 80 is going to smash 3.5 million easily. And, as we get older, we accumulate those changes that herald cancers. So,
fantastic. Thanks for coming to talk to us.
Thank you.
Right. So we've seen some fascinating things discussed during this episode, and hopefully that will stimulate some discussion and new ideas back in your hospital as to how to improve the care that rectal cancer patients receive locally. Remember, if you'd like to get in touch with the Iceni Centre through any of the routes shown here, then please do so to give your feedback, and we look forward to welcoming you next time. Goodbye.